we're very happy and grateful for the time of Dr. Michael Klumpus, who's going to be speaking to us today about the risk of healthcare worker infection of COVID-19. Dr. Klumpus is an infectious disease physician and the hospital epidemiologist at Brigham and Women's Hospital in Boston, as well as professor of population medicine at the Harvard Medical School. He's published widely on surveillance, diagnosis, prevention, and treatment of hospital-acquired pneumonia, ventilator-associated events, COVID-19, and sepsis. He was a member of the ATS-IDSA Guidelines Panel on Management of Hospital-Acquired Pneumonia, is currently co-chair of the SHEA Panel on Strategies to Prevent Ventilator-Associated Pneumonia, and serves on the Surviving Sepsis Guidelines Panel, which we all should be practicing. Dr. Klumpus, thank you very much for your time in advance. Sorry for the delay. As I said at the outset, we'll give you the time on the back end. Thank you, sir.
Not a worry. So thank you very much for the opportunity to be able to speak to you. Let me pull up my slides. Okay, with a little bit of luck, you're seeing them?
Yep, they look great.
Brilliant. Okay, let's go. So good day, good afternoon, good morning, wherever you might be. Thank you very much for the opportunity to be able to address the conference. I really appreciate this opportunity. I had the opportunity to visit Shiprock a couple of years ago and had some very memorable experiences over there, which I still stay close to me. Let's go for it. So these are my disclosures. Grant funding from CDC, Mass Public Health, and Agency for Healthcare Research and Quality. And we want to focus today on what's our latest understanding of COVID transmission. Now, as we well know, most infections with COVID are spread by people without symptoms. Here's an analysis by CDC calculating that 24% of people who spread COVID are never symptomatic and 35% were pre-symptomatic. So all told, about 2/3 of COVID's symptoms of COVID infections are spread by people who do not have symptoms at the time. And of course, that has important implications for understanding how the spread's taking place. If we were thinking that it was through coughing and spluttering, that obviously wouldn't account for the asymptomatic or pre-symptomatic individual. And in fact, if we quantify how long are people contagious for before they develop symptoms, it turns out it's about 2 days. So 2 to 3 days on average, people will really start spreading COVID before they feel a whit of any kind of symptomatology. This is mirrored by viral load studies, which demonstrate that a particularity of SARS-CoV-2 is that people do have very high viral loads before their symptoms begin. That's shown over here in blue, which is showing the viral load as a function of time. And it's in contrast to MERS, in which the viral load really peaks after symptom onset, and SARS. Now, this is the reason why I think SARS-CoV-2 has been so successful in spreading, but again, also has implications for us as to understanding how it is that it is spreading. And the viral load really is the key determinant of infectiousness. There are now a couple of studies that demonstrate that the higher your viral load, the more likely you are to spread COVID to other people. And so the viral load is the key determinant. Now, in terms of this question, though, which I think has rocked the society for the past 2 years, which is COVID spread by droplets or aerosols? Now, as you know, the traditional thinking of infection control has been that things like influenza, like COVID, like SARS, are spread predominantly by droplets. And I don't think that's true anymore. So here's an amazing photograph from MIT, in which this researcher has been able to capture both droplets and aerosols in a single image. So droplets are these shown in green over here. These are larger respiratory particles. They are big enough that they'll be carried to the ground by virtue of gravity, typically within a radius of 3 to 6 feet from the source individual. And by contrast, aerosols are much smaller respiratory particles. They are small enough and light enough to be able to remain suspended on the air for long periods of time, to be able to waft across the entire room and over long distances. And as you know, the field's been rocked by the question of which of these is the predominant factor in spreading COVID. Now, what this picture shows appears to be a dichotomy. There are droplets or aerosols. And of course, the biological reality is nothing like that. People are not dichotomous systems. Nature exists on a continuum. So if you actually measure the respiratory particles that a person emits under the course of routine breathing, talking, speaking, you'll find that they emit particles across a range of sizes it's a continuity, but the majority of the particles people put out actually are over here in the aerosol range. Now, there's no hard and fast dividing line when does something become change from being an aerosol to a droplet, but by and large, the stuff down in this range over here, the aerosols, the stuff over here is droplets, and you can see the majority of what we put out is aerosols. And can these aerosols transmit infections? Good animal studies showing absolutely yes. So here is a ferret-based study what you do is you take an infected ferret, you put it over here in the bottom cage, and then in order for the air to flow from this ferret over here, they have to go through 4 90-degree turns across this piping system. So 1, 2, 3, 4, in order to be able to get to the other ferret. They did this 4 times and showed that 2 of the exposed ferrets did indeed get infected, confirming that the aerosol transmission was possible over here. Now, the thought being that a droplet would have been stopped by any one of these 90-degree turns. So in practice, the way that transmission is felt to take place is that people are continually emitting very fine aerosols that are virus-laden, and it's the projection followed by the inhalation of these aerosols that leads to transmission. So here is some remarkable images over here. This one's from, let's get playing. This over here is from using a military camera, and it's able to pick up gases. And you can see over here that these very fine particles that we all routinely emit under normal talking conditions are felt to be the carriers of the virus and the means in which it goes from one person to another. Now, there are lots of things that impact the amount of those respiratory particles that a person might put out. The one that's well known is loud voice or swinging. So here's a quantification of aerosol emission, and you can see that the louder you speak, the more you put out. So here's loud voice, here's quiet voice, and intermediate, of course, is somewhere in between. And again, you can see, again, the majority of the respiratory emissions are down here in the aerosol range, not over here in the droplet range. The other thing that really affects respiratory emissions is activity. What you do and makes a big difference. So this is looking over here at fold increase in respiratory particles relative to quiet breathing alone. So if quiet breathing is 1, talking will increase your emissions 35-fold. Exercising, almost 60-fold. Shouting, 160-fold. Forced expiration, 228-fold. Coughing, almost 400 times. The other factor that really varies is person to person. Some people simply put out more emissions than others by virtue of their native biology. And so this is a number of different people reading the same English passage at the same level of volume. And you can see most people put out this many particles, but there are these so-called super emitters that put out this many particles. Now, you're starting to get a sense as to what some of the factors that might lead to more transmission or to more super spreader events. If you had a person who's just pre-symptomatic, who happens to have a very high viral load, who happens to be a super emitter, who's shouting or speaking loudly, that's the sort of scenario in which transmission is much, much more likely to take place. Now, there are mitigating factors, because I think that you might say to yourself, well, gee, you know, if this virus is carried upon aerosols, and these things can spread for 10, 20 feet, can spread across an entire room, how come we aren't all falling like flies? How come we aren't all getting infected all the time? And the answer is that although we know that droplets, we only worried about a 3 to 6 foot radius, it turns out that distance is highly protective for aerosols as well. And the reason is because of dilution and diffusion. So look at this over here. This is a visualization of a mannequin doing a cough. And here's a respiratory plume at 3 feet. Look what happens as you spread out further away from the source. So here it is at 6 feet, and here it is at 9 and 12 feet. So compare the density of the respiratory plume over here at 3 feet, over here compared to 12 feet. In other words, distance becomes your protection because it leads to dilution, which therefore decreases the probability of getting any virus, decreases the inoculum of virus that you might get. And so distance is highly protective. This has been borne out in epidemiological studies as well. Here's my favorite. This is a study out of China looking at about 70,000 plus train travelers, where they were able to link together where you sat on your train with your medical records, and therefore were able to identify who was a COVID index patient and who was potentially exposed. And it turned out that if you had the misfortune to sit right next to the index patient over here, to somebody with COVID, you had a 3.5% chance of getting COVID. If you were merely 2 seats away, so going from 0.5 meter to 1 meter, that dropped your probability of getting COVID in half. 3 seats away, you're down to almost 1/10 over here, 0.4%. So you can see this exponential decrease in infection risk as a function of distance. Proximity really is the key, is a key factor. The other thing they were able to demonstrate in the study was the impact of time, because of course these are train trips, and so you knew how long a person was potentially exposed for. So the longer the train journey, the greater the probability of transmission. So ranging over here from a journey of about half an hour, where your risk of transmission may be 0.2%, coming all the way up to here to a journey of 8 hours, where you might be getting 1.5 to 2%, almost a 10-fold increase by virtue of time. So proximity and time are key determinants. Now, there is a exception, this notion where that distance is protective. What this is showing over here is the Skagit Valley Choir. Now, you might remember this, this very tragic story took place back in March 2020, where the members of this choir got together and a very high fraction of them ended up getting COVID. Here is what the investigation revealed. So 61 members of the choir attended practice together on March the 10th, and 53 of them, 87%, developed COVID. 3 were hospitalized, and tragically, 2 of them died. Now, on the investigation, it turned out that one member actually had flu-like symptoms 3 days before practice, and later turned out to indeed be positive for COVID. This was a 2.5-hour practice. There was no masking. The participants sat about only 6 to 10 inches apart. But the cases ultimately were spread throughout the room. There was no clustering by seat location. The factor that turned out to be influential over here was ventilation. So when we said that distance is protective because it allows for dispersion of the virus and dilution, the exception to that is when there's very poor ventilation. Because if there's no turnover of the air, then you simply get accumulation. You get more and more of those suspended aerosols inside the room, such that you reach the critical threshold throughout the room at some point. And that's what's felt to have happened over here. They went back and tried to estimate what was the quality of ventilation in the space where they practiced. And they did that by measuring the air changes per hour and estimated it to have been 0.7 air changes per hour. Now, to give you some context, at a minimum, in a modern clinical space, we require 6 air changes per hour. So this was literally 1/10 of the air change standard compared to what we have in the clinical space today. An operating room, by contrast, will have 15 to 20 air changes per hour. So almost 40 times as much air turnover as took place inside this particular cluster. Let me tell you about another cluster which further elucidates this role of ventilation as a key determinant of both the risk and the protection against COVID transmission. This was a restaurant cluster in a city in China. The story was that this was back in January, before the outbreak really had reached its full force. This individual A1 over here had just come back from Wuhan to this other city and took out these individuals of their group for a celebratory dinner at a restaurant. And it turned out that this person infected 4 people at their table, as well as 3 people on the table to the left and 2 people on the table to the right. Now, some of these people were quite far away from this one individual, and they had video footage showing that there was no interaction, no direct interaction between the people from the other tables versus A1 over here at table A. It turned out the story over here was that there was an air conditioner on the far wall, which was blowing air from right to left. So the air was blowing in this direction, and there was an exhaust fan on the opposite wall, but it was closed. So what happened in practice is you set up an air circulation loop going from right to left to bouncing all the way back over here. And that's felt to be how the air went from A1 over to the people at table B, and all the way across the wall back to table C over here, a distance of over 12 feet for the people to get to C1 and C2. What you don't see in that prior image was that, in fact, this restaurant was much, much bigger than 3 tables. There were many additional diners inside that restaurant, and none of them got infected. So it turned out that people who are sitting at the back over here under the circulation loop set up by the air conditioner, 9 out of 20, 45% of them end up getting infected. Of the 68 other individuals in the same room, in the same airspace, none of them got infected. And the thought was that the air conditioner set up a protected air system at the back of the restaurant, and that even minimal amounts of dilution of that air with the air of the rest of the restaurant was enough to reduce the rate of attack down to 0. So you see over here, I think the 2 sides, the yin and the yang of ventilation. Very poor ventilation, very high attack rate. Even improving the ventilation now a little bit, right? You're in the same room, same airspace, but you're out of that immediate circulation loop, enough to drop the infection risk down to 0. Now they went and they tried to estimate again, what was the quality of the air change at the back of that restaurant? And magically they came up with the same number as in the choir study, 0.7 air changes per hour, which again is at least 1/10 of what we have inside of our clinical spaces. The third cluster I'm going to tell you about really brings out the value of and the limitations of outdoor air. So this was a cluster of 31 infections amongst 300 people who went to an outdoor Buddhist ceremony and lunch in Eastern China. And ultimately, this outbreak of 31 people was traced to one pre-symptomatic attendee. Now, the story was because this lunch was outside of town, people had to get there some way. And there are 3 different ways to get to the ceremony. You could take one of 2 organized buses, or you could go by private transportation. It was 100 minutes of travel time and 50 minutes of ceremony time, and the ceremony itself was outdoors. So on people who went on bus number 1, which happened to have the pre-symptomatic individual, 24 out of 68 got infected, so 35% of them. Again, bespeaking that in a closed environment with poor circulation, very high attack rates. Bus number 2 did not have the pre-symptomatic person traveling over there. And although they did actually spend time outdoors during the ceremony itself, a 0% attack rate, again, showing that outdoor air by and large is protective. However, amongst those who took private transport and also weren't traveling with a pre-symptomatic individual, 7 out of 172 did get infected, 4%. But it turned out each of those 7 had face-to-face close contact with the pre-symptomatic individual. The message over here is that poorly ventilated space is very bad, outdoor air, very protective, but not perfectly protective. If you're literally face-to-face with somebody for a sustained period, even in an outdoor situation or a situation with very good ventilation, transmission still can take place. Now, the value of good ventilation and outdoor air has in fact been known to medicine for over 100 years. Here's a poster from the flu pandemic of 1918. Keep your bedroom windows open to prevent influenza, pneumonia, and tuberculosis. And here's a picture of an outdoor ward in England, again, trying to take advantage of the benefits and the health benefits of outdoor air. So what about masks? Where does that fall into the story? Let's begin again with some animal data over here. This is a transmission study using golden Syrian hamsters who are placed in adjacent cages with or without a surgical mask between the cages. So you begin with the indexed hamster over here, and you expose it to 15 other uninfected hamsters. And using the setup over here, 67% of the naive hamsters end up getting infected. Then you put a mask on the index hamster's cage, so like masking the source. And that led to a dramatic drop in infections down to 17%. Not zero, though, not 17%, not zero. Likewise, if you put the mask on the exposed individual, so this might be us as a healthcare worker seeing a patient who might have silent infection, also reduces infections, but again, doesn't bring it down to zero. So what you see over here is that, yes, masks are highly protective. Putting the mask on the source is probably more effective than putting the mask on the exposed individual, but they are not perfectly protective. Now, why is that? And the reason is that because if most of the transmission is in fact aerosol-based, an ordinary surgical mask or a medical mask does not provide perfect filtration, perfect blocking of respiratory emissions. So over here is an analysis of medical mask overall efficiency. What you would like the particle penetration, of course, to be down to zero, but you'd see, in fact, it turns out to, in practice, to be around 30 to 40%, and will change as you move your mouth, as you move your head, which allows for basically more passage of respiratory particles to go around the sides of the mask. Here's a picture. This is a fellow I was rounding with a couple of months ago, and I was sort of standing behind her. She interviewed the patients, and I could literally see her mouth moving. And so it's not difficult to imagine the passage of respiratory aerosols either into or out of this mask through these very prominent gaps on the side. Again, it speaks to the fact that it's not enough to have a mask. You have to have a well-fitting mask. Here's another visualization from the Washington Post of showing just the escape of respiratory emissions out the sides and out the top of an imperfectly fitting mask. Now, this is all very nice in theory, but does it actually lead to infections? And through a number of very close contact tracing investigations we've done over here in our hospital, I think the answer is absolutely. So what we've done is we've been able to document multiple instances of transmission to and actually from healthcare workers despite wearing masks and eye protection. All of our transmissions were confirmed by whole genome sequencing, showing 0 single nucleotide polymorphism differences between the healthcare worker and the patient. Our examples include a patient infecting a CT tech, a patient infecting a video swallow technician, an asymptomatic inpatient who infected 2 patient care assistants, a pre-symptomatic nurse to a patient, a pre-symptomatic outpatient to a physician. And in the last case, both parties were masked and had no interaction other than sitting together for 45 minutes in a very well ventilated room. So can transmission take place? 100% it can. Now, we have the solution to this, and of course, that's a better fitting mask. In particular, N95s, probably KN95s, who of course are designed to be able to fit well and to block out these aerosols. So by contrast this 98% efficiency with the 38% efficiency we saw with a regular surgical mask or medical mask on the prior slide. And that's why CDC's recommendation is for a healthcare provider who's going to be caring for a patient with suspected or confirmed COVID, they should use an N95 equivalent or higher level respirator in addition to their gown, gloves, and eye protection. I'd like to be a little provocative though and ask you the question, should we be using N95s for non-COVID care as well as COVID when COVID rates in the community are very high. And remember, the premise for this statement is that, again, is the recognition that most of the people who spread COVID do not have symptoms. So if you're simply reserving your COVID care and your COVID N95 for the patients who have symptoms of known COVID, you're going to be missing almost 2/3 of the people who actually have active and spreading COVID. The other fact I want to point out is that, ironically, people who've been diagnosed with COVID and are sick enough to come to the hospital, particularly those who require admission or ICU care, ironically enough, tend to have the lowest of viral burdens. And that's because, as we know from our treatment approach or our treatment strategy for COVID, is that COVID really falls into two phases. There's an initial phase of viral replication, which is your fever, myalgia, fatigue. And at that time, we're going to treat a patient with monoclonals or remdesivir. But then there's this more inflammatory kind of a phase where you get ARDS or myocarditis or renal failure, neurosyndromes. And at that point, viral loads are down to almost nothing, if any, are very low or absent. And that's why in the later phase of disease, we don't use remdesivir or monoclonals anymore because it's too late. The cat's out of the bag. The virus is gone. We're dealing instead with the post-inflammatory consequences of the virus, and therefore we concentrate our treatment instead on things like dexamethasone or tocilizumab. What this brings home is a great irony, which is that the sickest of COVID patients are the least contagious. And by extension then, the patients who don't have symptoms and yet might have occult COVID are in fact the most dangerous to healthcare workers and to other patients. This is borne out as well by studies of cycle thresholds, which is the means by which we quantify the amount of virus inside of a specimen. Remember, the higher the cycle threshold, the lower the amount of virus, so it's an inverse scale. So if you have a very low CT count, particularly less than 20, that's when you get into the highly contagious kind of a range. This study over here from University of Pittsburgh compared the average cycle thresholds or viral loads in patients. You can see it's actually the viral load is very, very low, so high cycle threshold, low viral load. Outpatients and healthcare workers, who of course are being tested much more readily and even with minimal symptoms, they actually had the lowest cycle threshold. So again, this great irony that the patient who's isolated inside the hospital with COVID might be much less of a threat to you than the patient who is pre-symptomatic or your colleague, of course, who is pre-symptomatic. I want to switch gears a little bit and talk about the concept of aerosol generating procedures, because that's been a major driver of the infection control strategy in many places. Now, the concept of infection of an aerosol generating procedure is that there might be some medical interventions that increase the amount of aerosols a person is putting out. This observation really came to the fore with SARS-1, where a number of case control studies documented that healthcare workers involved in certain kinds of care were more likely to get infected with SARS-1. And in particular, tracheal intubation was the most prominent finding. So tracheal intubation was associated with a 6-fold increase in SARS-CoV-1 infections, and similar sorts of analyses also identified things like non-invasive positive pressure ventilation, pre-manual ventilation before intubation, tracheotomy, and cardiac resuscitation with increased risk of healthcare worker infections. However, if you go and you actually try to measure the amount of aerosols associated with these procedures, you'll find something very curious, which is that they do not generate aerosols. So here's an analysis of intubation and extubation. This is done under controlled circumstances inside of an operating room with an asymptomatic patient. And you can see over here, intubation associated with essentially 0 particles, extubation, almost nothing. And in both cases, a tiny fraction of what a person puts out if they cough. Here's a similar study showing identical findings over here, where they measured the aerosols inside the room associated with a number of procedures, including mechanical ventilation, non-invasive positive pressure ventilation, extubation, bronchoscopy and suctioning, and all associated with no aerosol production. The only exception was this, nebulizers. And of course, nebulizers are designed to produce aerosols, but to produce aerosols of medication, not of patient emissions. And so again, most of the procedures that we associate with aerosol generation, in fact, are not aerosol generating. Here's another study showing the same thing over here with oxygen delivery modalities, quantifying the amount of particles inside the air and showing no difference between a patient who's on room air versus nasal cannula versus face mask, high flow nasal cannula, non-invasive positive pressure ventilation, even with very high settings. So again, these things we have in our aerosol generating procedure list do not generate aerosols, with possible exception of nebulizers. Now, remember this figure I showed you before showing the quantification of the amount of emissions by activity. What I'd like to show you is where do some of these supplementary oxygen modalities fit into the scale. Here they go. So high flow oxygen, 60 liters per minute, non-invasive positive pressure ventilation with very high settings, and much, much less increase in aerosol generation compared to just talking alone, never mind exercise, shouting, forced expiration, or coughing. So then it begs the question, those healthcare workers who got infected through intubation, how'd that happen? And I would argue, based upon what we've covered together, it's not the procedure, it's the patient. That the associations between the procedures and healthcare worker infections are more likely due to the circumstance surrounding the procedure rather than the procedure itself. So if you think about it, when you're intubating a patient for SARS-1, what's the circumstance? Well, it's somebody who's highly symptomatic, who probably has a very high viral load. You have to be right next to their face for a sustained period. That's all the key risk factors: proximity, duration, severity of illness, and hence viral load. That are the more likely explanations for why healthcare workers were getting infected with intubation. Finally, let's try to do some quantification. What actually is the risk to healthcare workers? Here's an analysis of seropositivity from 25,000 healthcare workers from 4 US systems across 3 different states. And you can see over here that the risk factors for being seropositive had to do with age. So younger people more likely to be positive. Now that's a truism of the pandemic overall, that younger people are those who get infected most. Race and ethnicity. So you can see that white had the lowest risk, but other race ethnicities had higher risk. And again, that mirrors what we've seen nationwide. It's not particular to healthcare workers. Community contact for COVID was the most potent risk factor. The cumulative community incidence a little higher was a clear risk factor as well. The contact of the COVID positive patient, almost no risk whatsoever. And of course, we can understand that in context here. I think that it says 2 things are taking place. Number one is that most healthcare workers are actually getting infected inside the community, not inside the hospital. And when it does happen, it's not from contact with the COVID positive patients, because we saw together, those patients are actually amongst the least contagious within our hospital environment. So where do healthcare workers get infected? Here's a whole genome sequencing analysis from University of Wisconsin. And in most cases, they were able to confirm homology between the healthcare worker and what was happening inside their community or their household, occasionally from co-workers, patient-employee clusters, and only 4% were associated with a known COVID positive patient. So it gives you some good context to where people are actually getting infected. Finally, as we know, vaccines have had an incredible impact on healthcare worker infection rates. Just as we've seen a plummeting of infections inside society, we've seen the same thing amongst our healthcare workers. Here's just one analysis of that, but there are many more that show the same thing. I just want to then end off on one last note, which is that we are all, I hope now, vaccinated. As a vaccinated individual, is there any residual risk that we might be spreading COVID to others? And there are a couple of different windows into this question. I'll show you just 1 or 2 of them. One is that to look again at the quantification of virus inside people who are vaccinated versus not. And this is an analysis from Israel looking at time after vaccination. And amongst those who did get infected, what was the average quantity of virus? Again, measured using the cycle threshold, where again, the lower the cycle threshold, the more virus present. And you can see that after about 12 days post-vaccination, those who did get infected seem to have much higher cycle thresholds and therefore lower viral loads compared to those whom the vaccine had not yet taken a chance to have impact. So vaccination good in the sense that you're less likely to get infected. If you do get infected, you're less likely to have a high amount of virus. But that, of course, does exist on a continuum. So if you look over here across the population of people getting vaccination and you look at their cycle thresholds, while we can see that overall, people who are vaccinated, shown here in blue, did have higher cycle thresholds, there were certainly some in the blue population as well who did have very low cycle thresholds, where that risk of transmission does still exist. Finally, we do now have studies coming out of England, household studies, where we look at people, at healthcare workers who've been vaccinated and looking at their risk of transmission to other household members. And to give you sort of the long and short of it, a vaccinated person, if they do get infected, is about half as likely to transmit as somebody who has not been vaccinated. So let me summarize over here. SARS-CoV-2 is transmitted primarily by respiratory particles in a range of sizes, but mostly aerosols. The risk of infections associated with the amount of viral exposure, which is determined by the source patient's viral load, their quantity of emissions, their symptoms, their proximity, duration of exposure, masking and ventilation. Mass decrease exposure, they do not eliminate it. Some more transmissible variants might increase transmission risk. COVID patients that are sick enough to be hospitalized may be less contagious than those with acute infection with or without symptoms. Begging the question, should we be doing more to protect healthcare workers and patients in non-COVID units? Most aerosol generating procedures do not generate aerosols. And because most of what I said to you today, I would have said the exact opposite to you a year and a half ago, we all have to stay humble. Thank you.
Wow, Dr. Klompus, that was an incredible presentation, and I just behind the scenes, there's a lot of chatter in the chat and elsewhere about how we're processing this information, because there's a lot you've shared with us. There's a couple of questions I want to get to from our attendees, and the first is, and I've got several, which is why I'm stuttering along here, but the first from Mark Robideau is, could you comment on airline travel? Can we go to ASAP, as Dr. Rosenberg invited us to in October? We hear that there's up to 20 cycles in an airplane cabin per hour. What are your thoughts on that, if you're willing to comment?
Yeah, no, so it's a great question. I think one that's very much on all of our minds. There are a number of factors at play. So if we go through the key factors, which is, first of all, what's the community incidence of COVID? Because if there's very little incidence inside the grander community, then the odds of somebody having COVID who's next to you is, of course, going to be much lower. And of course, we're in an increasingly better state as we sort of move into the summer. And if that continues, and I hope there's no sort of fallback by October, I think from that perspective alone, I think you'll be in very good shape to be able to hop on an airplane. The other factors, of course, then to take into account is proximity. So what's the probability the person sitting right next to you might actually have COVID, and how long is your actual flight going to be? I would extrapolate a lot from that train travel study, where we saw that if you did sit next to somebody who had COVID, you had a 3.5% risk. That was in the context of Wuhan, sort of at the height of their particular outbreak. And so what I would do is sort of simply take stock of where are we as a community in terms of incidence rates, prevalence rates as we come the fall. And so long as things are kind of looking the way they are now, I personally, and you're fully vaccinated, I would go for it.
Well, you heard it there, and I see Ken unmuted that he's got a question. I just wanted to make a quick comment and turn it over to Ken, and hopefully I get a chance to ask a couple more questions. It is strikingly refreshing to have such a presentation with such a high level of confidence behind it, in contrast to the bygone era of, say, May 2020, when everyone, we were seeking the answers everywhere, and folks, leaders like yourself, were giving us the best information. It's just it comes with a relief to hear and see the hard work that's been done by folks in the IDSA and others to bring us the data to offer a presentation like this, where there's a much more high degree of confidence.
Thank you.
Just a quick editorial on that. Yeah, Ken Bernard.
Yeah, I just want to break in and share Sean's sentiments about that. Was an amazing talk, counterintuitive, surprising, and mind-blowing, and very eloquently given. I love your accent, New Jersey, right?
Jersey, South Africa.
Got it.
Yes, right.
But the one question that I had is to take that the controversial point that you had about masking even with non-COVID patients. I would take that further to say, epidemiologically, have you guys experienced similar to what we have here in the rural settings in Indian Health Service, where I haven't diagnosed an influenza patient during this respiratory season, nor have I admitted a bronchiolitic child to the hospital? And does that have to do, would you consider expanding these guidelines of socially distanced, no large gatherings, as well as universal masking, especially for people with respiratory issues and comorbidities during respiratory season moving forward? Meaning, if you were the man on the socks, I think, that are over your left shoulder, or Dr. Walensky, would you consider making those recommendations to our legislative bodies and our policymakers?
Oh, such a good question. So first of all, I think as implied by your question, what we've learned about COVID transmission applies to other viruses as well. And in fact, there was a small sort of cadre of experts in the field who'd been saying the same things about influenza for many years before COVID came along. And sort of COVID came along, and they sort of shouted, "Hey, we know the answers over here," but nobody listened to them for months and months. So all these dynamics play true as well. Your second point, that we've seen sort of a near elimination of influenza, RSV, other kinds of viruses, of course, has also been documented around the world. One curiosity about that is that as different societies have opened up, they have reported resurgences of some of those pathogens. Hong Kong reporting this with regard to RSV, Australia reporting this with rhinovirus. So there is some sense that we might be in for a bit of a comeback. It begs the question as to why we saw that. Part of it has to, I think, do with social distancing and masking, as you implied. There might also be some aspect of competition between different viruses for residence inside the human respiratory tract. That's all speculation. I don't actually know. So whether we should be applying this, I think, in the future to future respiratory virus seasons, I think that's going to awaken the same kind of debate we had this year about all the sort of the collateral cost associated with masking, distancing, closing schools, shutting down businesses, so on and so forth. And I would venture to say that the answer is going to be we can't do that. We cannot live our lives that way. That has too much collateral cost, but economically, socially, mentally, so on and so forth, to be able to sustain that. What I do think we could do, though, is apply some of those lessons to people who are more vulnerable, so immunocompromised individuals, what have you, those who have immunocompromised person in the home, might want to take stock and recognize that they can choose individually to do more of these measures. And I do think that inside of healthcare settings, that we might want to absorb some of these. So in other words, we might want to be wearing masks during certain times of the year. Even pre-COVID, some places actually did do that, particularly for those with high immunocompromised patient populations. And I would argue that should be one aspect we should try to carry forward into the future.
Dr. Klumpus, could we stay on that thread for another minute with the following question? Thinking of the folks may have forgotten, we had a pretty bad flu season, 2019 into 2020. I'm thinking of a couple of cases of nosocomial infection that I had observed during that season. So there's a part of the purpose of this conference is we invite clinicians and also clinical leaders. And so we've got a number of emergency department and some hospital leaders on the call. So my question is, when we're controlling budgets and we're looking to expand, as Dr. Baugh had described earlier, the footprint of a department or the footprint of a facility, are there changing standards that we should consider? For example, should we build our next ED all negative pressure? Being mindful of that when we do that, it's negative pressure relative maybe to the waiting room, but not necessarily person to person within that space. Should we be thinking about that when we consider how we're growing or evolving our operations?
Yeah, another really good question. If anybody else who's on the call wants to sort of share their thoughts as well, I would love to hear them. I think that a couple of observations. I mean, one is that to the extent that we can eliminate shared spaces for patients, that'd be highly desirable. So being able to take care of a patient inside of an enclosed space, I think would be a key infection control premise. Now, in the inpatient units right now, we still have many patients inside of shared rooms. I think about 70% of our patients are in shared spaces. Now, as a colleague of mine is fond of saying, if you go to a Motel 6 and you pay $80 a night, you can get a single room. Why are we doing this to our patients when we know about the infection transmission risk? I recognize that in the emergency departments that are typically overcrowded, that the capacity to be able to offer a single space to every patient might be very difficult to imagine in the current era. But perhaps something like COVID brings home to us the fact that there is a collateral public health benefit to that. And so if you're phrasing it as you did, as sort of blue sky dreaming as to what you might do in a facility of the future, that would certainly be a design feature I'd want to have. In addition, I think that there are ventilation standards that one will want to, at the very least, meet. The ventilation standards are a little bit interesting in that they apply to clinical spaces. They don't apply to shared spaces. What we've learned, I think, is that the shared clinical workspaces might actually be as much of a risk of a threat to our healthcare workers for transmission as a clinical space. And so extending that minimum, say, 6 air changes per hour from clinical rooms to also, say, break rooms and work areas, I think would also probably be a wise addition. Having the capacity to be able to flip a room onto negative pressure would certainly be helpful. There is debate as to what the marginal benefit of negative pressure is over and above good ventilation, good native ventilation inside a room. We don't really have good data to inform that. Our general experience is that we don't really see much transmission taking place beyond the room, even in patients who are not inside of negative pressure spaces. So it's not clear that there is a value proposition to that. And because most of the negative pressure spaces right now are being preferentially given to patients with aerosol generating procedures, that also might be a misconception as to where the need might lie. So I do think that that having the capacity would be wise, but it's actually difficult to make a hard and fast argument that it's an absolute necessity to have vast numbers of negative pressure spaces. So those are some sort of early thoughts.
Thank you for that. And you had touched on in your comments just now a question that had come up. Has there been a study that we should be aware of on COVID patient transmission from a patient who's in isolation or negative pressure outside of that room? It sounds like there has not been substantial documentation of that.
No, so there are lots of studies that have tried to identify COVID basically inside the air in different kinds of clinical spaces, in nursing stations, in hallways, and you can do it. You can find it outside of a COVID care room, negative pressure, neutral pressure, or otherwise. But it comes down to, again, this question of what's the inoculum effect. There's a minimum threshold that you require before a person is likely to get infected. So simply being able to isolate a virion or two, in the shared space doesn't necessarily mean that the people who are inside that space are at risk. We did have a large COVID cluster inside of our hospital, in which a patient who turned out to be in a positive pressure space that led to a number of infections inside the ward. But we don't know if that was because of air coming from inside that room to out to the shared space, or because of healthcare workers going into that space, interacting directly with that patient, then coming out and interacting with one another. And again, the majority experience has been that healthcare workers, by and large, are not getting infected at work.
But that brings up a good point about the difference between positive and negative pressure. I had the good fortune to have worked at your facility for about 3 years. And so I know we had a patient population that demanded a fairly widespread use of positive pressure ventilation. Not the case where I work now in Fort Defiance, but without going down into that rabbit hole, I think folks should be aware, based on those air conditioning slides that we saw, that there could be theoretical implications to an inappropriately applied use of positive pressure ventilation. So that seems like something to be mindful of based on your data. Ken, I see you unmuted there. Nothing. Okay. A couple more quick questions, Dr. Klumpus, if you have the time here. One question that came up: do we know about transmission susceptibility for a surgical mask, vaccinated person? So, anybody who's received a vaccine who's wearing just a standard mask, non-N95. Any thoughts on the risk? I guess in a healthcare setting is how I'm taking this.
Yeah, the way I would think about it is it's like building a wall of protection, and that every measure you put into that wall is going to decrease your probability of getting infection. So if you begin with, say, pre-screening patients and pre-testing patients, and you add on distance, and you add on quality ventilation, you add on masking the patient, you add on masking yourself. So vaccinating is a very big brick you could put inside that wall, and that in itself is going to provide a sort of a very powerful level of baseline protection. You add on that mask, it's going to add some additional protection above and beyond that. I don't think we'll get you up to 100%. And quite frankly, I don't think much will get you to 100% other than sort of sitting in a box all year. But I do think that collectively is going to add that combination of vaccination plus masking is going to put you into a very safe space, but not a perfectly safe space.
Great.
One just other thought on that, just to add, is that while it's very clear that vaccinated people can get infection, we've documented it many times now. It's very rare for them to actually get sick. So a couple of days feeling lousy, but to be hospitalized or to die, extraordinarily unusual. So that should be taken into account as well. So that it might not be perfect protection, but worst comes to worst, you'll have a lousy couple of days, but you're not necessarily going to be in any kind of dangerous situation.
Speaking of dangerous situations, do you have any comment around the break rooms adjacent to departments and hospitals? Your data strikes me that we take exquisite care of ourselves and our colleagues when managing a patient who's been intubated, but there's fairly, free socializing happening. Do you have any? This is maybe an opportunity to speak to folks who run staff of departments.
Yeah,
with
no,
regard
100%. This is the total irony, right? Which is that we are a greater threat to one another than our patients are to us. Partly because the patients, again, are less contagious. Partly because we take such extraordinary care and concern with the way we interact with patients, and we tend to assume that people we work with. The culture is we see them as friends and family, right? And that just like I don't think of my family as a threat to myself, I don't think of my colleagues as a threat to myself either, particularly when I spend long amounts of time with them and I know them very well. The psychology is you assume that they're fine and I'm fine. But the truth is that when there's a lot of COVID going around, that the odds of them being a silent COVID carrier is non-trivial. And then if you then go and you have a face-to-face conversation with them without a mask because you're in a break room or a work room at proximity, that's a very high-risk circumstance. And that's been very well reported that hospitals have reported that break rooms and work rooms have been a major source of healthcare worker infections for them, not patients, but colleagues.
And it is an irony because those protected spaces, socially speaking, are so sorely needed, at times like this. A couple of final quick questions that emerged, and again, just can't thank you enough for such a rich discussion here. Dr. Iyer had a question about fomites. What's the current thinking about fomites and potential transmissibility? And as a second question attached to that, what are the implications for room turnover as well? So there's another question about ED room turnover time. Do we need to let those rooms sit for a while? So fomites and then room turnover time in the ED.
Yeah, the prevailing opinion is very much is that the vast majority of transmission takes place through the respiratory route and not through fomites. If you think about it, we spend a lot of time talking about how viral load and inoculum was sort of the key determinant of your risk of infection. If you now apply that to a fomite sort of situation, you could imagine that, say I am exhaling COVID right now, it's going to be spread widely across the environment, so that any one spot I might touch is going to have a much smaller amount of COVID. And then the amount of that is going to get onto my hand, they get onto my mouth or onto my nose, it's going to be diminished that much further. So you have multiple layers of dilution with regard to fomites, both with the net amount on the surface itself as well as the amount that's likely to be transferred to my respiratory tract. I think that's the reason why in practice fomites do not turn out to be a major source of transmission at all. And so washing your hands is always a good thing. Washing your environment, a good thing for reasons other than COVID, but not a key COVID protection measure. And with regard to turnover of rooms, it comes back to quality of ventilation again. If you have a clinical space that meets standard ventilation minimums of at least 6 air changes per hour, that means that air is being constantly turned over, and the risk of residual virus hanging in the air after you discharge a patient from that space is going to decline exponentially with every successive minute. So in practice, by the time you actually if you clean that room and get a new patient inside there, the risk is essentially null.
Thank you very much for that, Dr. Klumpus. And the only risk I see in your discussion is that it is so rich, it is so full of good information that it leads to a lot of pensive chin scratching and a finger on the side of the nose. So we all need to be mindful of that. I caught my friend Ken Bernard doing that as well. So Dr. Michael Klumpus, thank you so much for your time. I apologize for some schedule shifting that happened earlier. We're hopefully releasing you on time. We're all better prepared for our next patient encounter and for our next staff meeting and for our next budget planning session because of your presentation. Thank you very much for your time today.
Awesome. Thank you very much. I appreciate it.